احضر على الفيسبوك يا عبود.
بابا بعد 5 دقائق نبلش.
أي ساعة بتخلص؟ على 5:30؟
6 على 6. يلا اوكي.
امتى عندك كمان محاضرة؟ كنت بدي
الجمعة اللي بعديها بابا.
عن شو الموضوع؟ عن شو الموضوع؟
عن ذوبان السن. Can you hear me? Hello. Bismillah ar-Rahman ar-Rahim. I hope everyone can hear me now. So today is the first day in Ramadan. So happy Ramadan for all the Muslims in all the world, and I hope safety for all people in the whole world. My topic today will be about root resorption. And just I'm checking if everyone can hear me now. Can you hear me? Okay. So I chose this topic because I think it is one of the most complicated thing which we face in our clinics. So during the next 45 minutes, I'm going to share with you the causes and the management of root resorption. But let's take a quick look about the tooth anatomy. If we look at the tooth, we are dealing with two parts. The first part, it is enamel, dentin, and pulp, which is called endodontia. And the second part, it is what we call periodontium, which contains cementum, periodontal ligament, and alveolar bone. So here is a deeper look for the tooth. This is enamel, dentin, pulp, and outside we are dealing with cementum, periodontal ligaments, and alveolar bone. Let's take a look about the enamel. And the enamel, it is the most mineralized tissue in the body. The mineral contents is generally over 97% in weight. And it's mainly composed of various calcium phosphate. The second mineralized part in the tooth, it is the dentin. and the dentin is soft, flexible, tough, and avascular mineralized tissue that forms the bulk of the tooth. So for the dentin, the mineral content, it's about 70% in weight. So here is the dentin, and it is crossed by channels 0.5 to 3 micron width, radially depending from the pulp. Those channels are called dentinal tubules. And if we go from the coronal part to the apical part, the width of the dentinal tubules becomes bigger. Inside the dentinal tubules, we have three main parts. We have odontoblast process. We have dentinal fluids. My topic today will be. And we have nerve fibers, which are dentinal pulp complex. Then the third part of the endodontium, it is the pulp, which is non-mineralized part inside the tooth. Pulp is not mineralized, and it consists of specialized loosely connective tissue. So here is a look on the pulp and dentin. If we look closer to the pulp and dentin at the junction point, we can notice here between the pulp and the dentin, we are dealing with a layer, and this layer, it is between 2 to 6 micron thickness. It is called predentin. And please remember this name, predentin, because it is very important in our topic today. So this layer, which is called predentin, it's in the thickness is between 2 to 6 micrometer. And here is the predentin, which is unmineralized organic matrix, and it is important in maintaining the integrity of the dentin. So now we are looking at the odontoblast, then predentin, then dentin. And remember, predentin, it is unmineralized layer. Then we will go to the cementum, and the cementum is less mineralized, 45% in organic material, and the 55% are organic material. And the cementum, the main function of cementum, it will protect the root and also serves as an attachment surface to anchor the periodontal ligament. So here is a closer look to cementum. Cementum is thinner near the tooth, neck, about 20 to 50 micron, and about 150 to 200 micron at the root apex. So this is the cementum, this is the dentin. Now, if we look at the cementum, it is divided into two types, acellular and cellular. So here we are dealing with dentin. Next to dentin, we are dealing with cellular cementum, then acellular cementum, then we will go to the periodontal ligament. So let's take a look at the junction between dentin and cementum. The outer layer of cementum, which is closer to dentin, there lie a thin layer, 3 to 5 micron, and this layer is also non-mineralized, and it is called a pre-cementum. Now, to remind you, we are dealing with, from outside to inside, alveolar bone, then periodontium, then cementum, then dentin, then the pulp. Now, we talked about two important layers. The first layer is between the pulp and dentin, it is called pre-dentin layer, and this layer is non-mineralized. And the second layer, it is between the dentin and the cementum, and it's called pre-cementum, and it is also non-mineralized. Please remember those two layers because they are the most important layers which will protect the dentin from resorption. Let's go. These two layers that form the barrier against the resorption. So here, from internally, from the pulp surface, there is a pre-dentin layer, and this layer is non-mineralized. And the second layer is between the dentin and cementum. It is called a pre-cementum, which is externally from the periodontium. So those two layers, pre-dentin and pre-cementum, they are playing very important role in protection of resorption. They will prevent odontoclast from adhering to unmineralized matrix, so root is resistant to resorption. And when we talk about resorption, which is our topic today, we have to define resorption. It is the loss of hard tissues, dentin, cementum, or bone as a result of clastic activity. And when we talk about clastic, we are meaning the cells osteoclast and odontoclast. So for root resorption to occur, we need two things. First, we need to lose or alteration of the pre-cementum or pre-dentin by an injury. So if we have an injury and this injury affect either pre-dentin or pre-cementum layer, resorption might occur. Second, we need a stimulus, either inflammation of the pulp or inflammation of periodontal tissues. So here we have resorption, and those resorption occurred due to first loss or alteration of the protective layer pre-dentin and pre-cementum. Second, we have an inflammation or infection in the pulp or periodontal tissues. When this alteration happens in these layers, the clastic cells, which are multinucleated, will induce resorption. And when we talk about clastic cells, we have two types of clastic cells, osteoclast and odontoclast. And they are probably the same. I did not find a lot of difference between those two types of clastic cells, osteoclast or odontoclast. So here, the osteoclast, they are motile, they are mobile. They have multi-nucleus, and they are giant, and they are responsible of bone resorption or tooth resorption. So when we say osteoclast or odontoclast, it is the same function. Osteoclasts are recruited to the site of injury or irritation by release of many pro-inflammatory cytokines. And when we talk about resorption, we have to make the classification. And the most popular classification is for the Andreasen. He classified root resorption according to the location into two types, either internal resorption inside the tooth or external resorption outside the tooth. So let's talk about internal resorption. It is a form of root resorption that starts within the root canal due to chronic inflammation of the pulp. So now you can notice here, it is inside the root canal, and it is due to inflammation of the pulp. So here is an example of internal resorption which occurred inside the root canal system. Internal resorption is a relatively rare occurrence. We don't see it frequently. And its cause or etiology, it's unknown. It's not clear exactly why internal resorption happens. Now, how it occurs? Remember, we said between the pulp and dentin, we have non-mineralized layer called predentin. So when this predentin is damaged, what will happen? The infected coronal pulp tissue, it will provide stimulation for those eclastic cells, and the osteoclast will be activated. Then it will go to the dentin and it will start make resorption. And because of this, internal resorption occurs at this stage. We have several etiological factors which might cause loss of predentin, like orthodontic treatment, cracked teeth, or idiopathic dystrophic changes. We don't know why. But still, trauma was found to be the most common predisposing factor. It is responsible for about 45% of the cases examined. So 45% of internal resorption occurred due to trauma. Another important notice in internal resorption, the tooth should be vital. So vital pulp tissue is a prerequisite for active internal resorption. So if internal resorption wants to start, the pulp should still be vital. So why vital? Because blood supply will provide eclastic cells and their nutrients. So because we need osteoclast and odontoclast, those odontoclasts, the source of those odontoclasts are from the blood supply of the pulp. If we don't have a bacterial infection inside the pulp, what will happen? The resorption is transient and asymptomatic and limited. It may not advance to the stage that can be diagnosed clinically and radiographically. So if we don't have stimulus, I mean bacteria, that means the internal resorption might not be diagnosed or might not be seen radiographically. If we examine the vitality of the test, of the pulp, it is vital. In the more advanced stage, in the active stage of resorption, bacteria might enter the pulp canal through dentinal tubules or carious cavities or cracks or fracture or lateral canal. If bacteria enters, what will happen? It will stimulate the resorption, and the bacterial contamination of the vital pulp, it will cause acute inflammation of the pulp, and then clinical symptoms of pulpitis will occur. If the patient did not go to a dentist, this will advance to pulp necrosis. Then the bacteria will colonize the root canal space. Then acute or chronic apical periodontitis might occur. If the internal resorption continue, what will happen? It might be associated with root perforation like here. If you look here, we have this radiolucency inside the tooth, which means it might be internal root resorption. And this internal root resorption, it was continuing to cause perforation of the tooth. So this is another case here. We have big internal resorption, and unfortunately the patient did not go to dentist. This resorption advanced and it appears as circumscribed, oval-shaped enlargement. We have a problem in diagnosis of internal resorption because radiographically, using the two-dimension periapical X-ray, we could not actually know if there is a perforation or the resorption is just inside the root canal system. We could not make such differentiation based on periapical two-dimension X-ray. Because of this, the cone beam computed tomography or CBCT is useful to know whether the resorption has perforated the root canal or it does not. So nowadays, when I look at this X-ray and anyone asks me, is this internal resorption or it might cause perforation of the root, I could not give him an answer. I will ask him, please, I need CBCT, small field of view for this tooth to differentiate and to know the proper diagnosis. And every time I take CBCT, sometimes I was shocked because like this case, we have a resorption here, and this resorption caused the perforation of the tooth. So don't rely on two-dimension X-ray, and if you have resorption, think always about the CBCT. Another case here, we have resorption. Is it internal or it might cause perforation? I could not guess. I will ask for CBCT. CBCT told me we have perforation here. What about treatment of internal resorption? Conventional endodontic therapy to stop the process at an early stage and prevent the onset of perforation. When you see internal resorption, you should interfere immediately because we are afraid this internal resorption might progress and cause perforation. So the first step to do is doing root canal treatment, conventional root canal treatment. The hard tissue defect caused by the resorptive process are challenging to fill adequately. And when we have internal resorption and we want to fill it with our obturation technique, it is difficult. Because of this, we need Guttapercha gun. And Guttapercha gun can produce the best result for obturating hard tissue defect caused by resorptive process. And luckily, with Baker, they have their obturation system, which contains two parts, the down pack device and the backpack device or the Guttapercha gun. So let's see here. After filling the apical part of the canal with the down pack obturation technique, we will use the Guttapercha gun, which we use the flowable composite, flowable Guttapercha to fill the resort part with this gun. So let's see here what we will do. Here, so we used here the Guttapercha gun to fill the resort part or the remaining part of the canal. So like here, we have here internal resorption. So apical part is filled with down pack obturation, and this part we will use Guttapercha gun. And with this technique, we can fill adequately the resort part of this canal. Here, the apical part is filled with the down pack technique. And this part here, we will fill it with the Guttapercha gun. Of course, we have to use sealer and flowable Guttapercha with the getaperca gum. This part is filled with down pack and this part with the getaperca gum. What if we have perforation by internal resorption? We will manage this as we manage the perforation. We will use what we call hybrid technique. Hybrid technique means we will fill the apical part with the getaperca. Here we have internal resorption. So the apical part here is filled with the down pack technique. And with Baker, they have their device to fill the apical part. So let's see how we will fill the apical part using this device. So now the apical part, we place getaperca, and we will use this device, which will fill the apical 4 or 5 millimeter. So let's see here. Now you can see here, the apical part is filled with getaperca. We will use this getaperca as barrier to prevent our MTA, which we will use to prevent this MTA to go further than what we need. So let's see here. This is the apical part filled with the getaperca. It is used as barrier. Now we will take MTA or biodentin, whatever we want, or BC putty, to place this MTA inside the resorption. So getaperca can then be used as barrier against with the MTA, which can be packed at the apical part. Now, this is the MTA, and then the coronal part was filled with the MTA. And let's see the follow-up after seven months. You can see here. You can see here with the follow-up. So this is the part of the internal resorption. And let's go for the second part, which is the external resorption. And regarding external resorption, we have several types of external resorption, like surface resorption, invasive cervical resorption, inflammatory resorption, replacement resorption, and ankylosis. So let's see the first type of the external resorption, which is invasive cervical resorption. Invasive cervical resorption, it is insidious. It happens without any alarm, and often aggressively destructive for that invade the pulp space. So this is the cervical resorption. And let's back to cervical resorption. Remember, we talked about two layers which protect the dentin, the pre-dentin from inside and the pre-cementum from the outside. So if anything happens to this part, which is pre-cementum, like injury or infarction, this protective layer, which is non-mineralized, it will be damaged. Then the clastic cell, osteoclast, odontoclast, it will bind to the underlying dentin, and then those osteoclasts will enter inside the dentin and will cause the resorption. So, and because the resorption occurs at the cervical margin here, we call it cervical resorption. Unfortunately, the cause of cervical resorption, it's poorly understood. We don't know exactly what caused the cervical resorption, but we have what we call predisposing factors, and like orthodontic treatment, dental trauma, oral surgery, periodontal therapy, bruxism, intracoronal bleaching. Those might cause the cervical resorption. Now let's see how to make the diagnosis of cervical resorption. Clinically, a pink or red discoloration may develop at the cervical region of the tooth. And this is what we call pink spot. And this is the first sign you can see when you examine this tooth. And sometimes our patients might come complaining of this pink spot. Here, this pink spot, it might be buccally or labially or palatally. Here it's palatally pink spot. And this is the cervical resorption. So the first sign, it is the pink spot. And why pink spot occurs? Pink spot is due to the fibrovascular granulation tissue occupying the resorptive defect. So the cervical resorption is asymptomatic. And once the bacteria colonization of the site of resorption occurs, what will happen? Now the patient might feel the symptoms of pulpitis, sharp, severe pain, continuous pain, and this stage occurs after the colonization of the bacteria. Sometimes some patients, they might feel, they might notice a draining sinus or even buccal sulcus swelling. Like this patient here, he visited me suffering of this sinus with no pain, nothing. So he came just, I want to know what's happening here. I took X-ray and unfortunately you can see here this whole part was destroyed by resorption. The resorptive cavity advances, it communicates with the periodontal ligament, and again it might cause perforation like this here. Here, if you notice, we have in this two-dimension X-ray, we have this radiolucency. So if we want to know what's happening here, this is clinically, and you can see here the pink spot. And once I see this pink spot, it is a bad sign of cervical resorption. It means we have a resorption, and with the cone beam, you can see here big resorptive defect. Another important examination we can make, it is when we use our probe. A probing of the resorptive defect or the associated periodontal pocket. If we examine with our periodontal probe, we will notice a resorptive defect or associated periodontal pocket causes granulation tissue and it will bleed profusely. So a lot of bleeding when we check this pocket. Like here, when I check this, we have pink spot here. When I check this defect, a lot of huge bleeding because of the granulation tissue which filled the resorptive part here. And you can see here with the cone beam, you can see this perforation due to resorption. Again, cone beam, it's useful to know whether the cervical resorption has perforated the root canal and the extent of such perforation. So we need, like here, you will tell me, okay, so we could not see anything, but we can see a slight pink spot. When I took my periodontal probe, it was a little bit, there is bleeding here. I took periapical X-ray and you can see here radiolucency. So why I need to take cone beam? I need to know what is the extent of this resorption. And you can compare between 2-dimension X-ray and let's see the CBCT. Let's see the CBCT, small field of view for this canine. You can notice here, this is the cervical resorption, which we could not appreciate how much is the extension of this resorption depending on the periapical X-ray. Let's continue this video. When you look at the sagittal view here, you can know how much we have a cervical resorption here. And this cervical resorption, it affected the pulp, and we need now to make root canal treatment. Now, what is the treatment of cervical resorption? First, what are the objectives of the treatments? The objectives are, first, we have to remove the resorptive defect. We have to remove all of the tissues or granulation tissues, and I like to use the ultrasonic scaler to remove such granulation tissue. Then I will go to endodontic treatment, which is necessary when the resorptive process has perforated the root canal wall. So if it affected the root canal space, I have to make root canal treatment. Then I want to stop the resorption itself. So the cavity may be treated with 90% aqueous solution of trichloroacetic acid. This trichloroacetic acid will cause coagulation, necrosis of the resorptive tissue. Then, after finishing our treatment, we want to restore the hard tissue defect. If it is on the anterior teeth, we can use composite resin or glass ionomer cement. So we have to restore this part. Some they used biodentin, and then over it they can place the composite filling. Personally, I will go directly to composite filling. Then I will monitor the tooth for recurrence. So we have to take X-ray after 6 months, 12 months, and we have to make regular follow-up. So let's back to our case here, which we have cervical resorption here. So I will make root canal treatment. Then I have to make a surgical intervention. So I will make a flap here. Then I will clean the granulation tissue by ultrasonic scaler. Then I have to stop I have to place chloroacetic acid. Then I will place composite filling. And you can see here the filling, which was placed here. And unfortunately, you have to expect we might have a gum recession like this here, but fortunately the resorption is stopped, and you can see here after a few months of treatment. The second most important part of external resorption, it is external inflammatory resorption. And they consider it the most common form of external root resorption, and it is a progressive condition with potentially sudden onset. The most common cause of inflammatory resorption is trauma, either luxation or avulsion. In case of luxation, the prevalence of inflammatory resorption after luxation, it's between 5 to 18%, while after a avulsion of tooth and replanted it, we have 30% of a chance to have inflammatory resorption like this case. What is happening when we have a trauma? Traumatic dental injury, luxation or avulsion, and we take this tooth and make replantation if it is avulsed. What will happen now? It will cause injury to periodontal ligament. And this injury, it will affect the protective layer which we mentioned previously, which is the pre-cementum. Now, the tooth here, the outer surface, it's covered by pre-cementum. And this pre-cementum, which is non-mineralized layer, it will protect the dentin. So when we have a trauma, what will happen? It will damage the pre-cementum layer, and next, exposure of the underlying dentin to osteoclast activity to remove the damaged tissue. So now there is nothing will stop the osteoclast from entering to the dentin because we lost the pre-cementum. So those osteoclastic cells will enter inside and they will cause external resorption like what happened here. So now we have external resorption of this tooth because of the loss of the protective layer, which is pre-cementum. External inflammatory resorption can be identified histologically 1 week after replantation. So if we have a avulsed tooth and we replanted it again, after 1 week, if we examine it histologically, we can notice resorption. But radiographically, we need between 2 to 4 weeks after replantation to notice the external resorption in the X-ray. Conventional X-ray, two-dimension X-ray, underestimate the extent of inflammatory root resorption. And of course, CBCT is significantly better than intraoral periapical X-ray to make a diagnosis of inflammatory resorption. So if you look here, in the periapical X-ray, I don't distinguish what's happening here, but with the CBCT, you can see the extent of the resorption here and here. Of course, when we have avulsion and replanted, the response to vitality test is negative. Now the pulp is necrotic, and the necrotic infected pulp, it will stimulate inflammatory response over large area of the periodontal ligament. Then aggressive and progressive resorption of the root, it will occur. Because of this, the entire root surface might be resorbed within 3 months if the tooth is left untreated. So if you have a avulsed tooth or luxated and you replanted it or you fixed it, you have a probability of having resorption immediately after 1 week histologically and 2 to 4 weeks radiographically. And if you do not treat it, what will happen? The entire root might be resorbed like this case. Unfortunately, we lost the tooth because the patient did not visit his dentist after treatment and the resorption occurred. External inflammatory resorption is always accompanied by resorption of bone. So when we have resorption of root, it is combined by resorption of bone. What is other causes of resorption? Initiation of external inflammatory resorption require a source of stimulation like pressure. Persistent pressure on the root surface during orthodontic treatment. Unfortunately, sometimes the pressure during the orthodontic treatment, it's extreme. So what will happen here? You can see here, this is a patient who made orthodontic treatment a few years ago, and you can see here the resorption at the apical part of the root. Here, this patient, she made orthodontic treatment in March 2016. And in December 2016, you can see when this patient visited me because the tooth here is discolored. So she came to check what happened. And when I checked the vitality test, it is negative. That means the tooth is necrotic. When I took X-ray, you can see, and the CBCT here, you can see the resorption. So orthodontic treatment, if it is aggressive, it might cause the resorption of the tooth. Another cause of resorption, pressure on the root surface from impacted tooth. You can see here, this impacted premolar caused resorption of this of the mesial root of the first molar, and you can see here the resorption. Fortunately, the distal root, it did not resorb yet, but the mesial root has resorption. A pressure on the root surface from the cyst or tumor, you can see here we have resorption here due to pressure of this big lesion. In such cases, the resorption tends to stop as soon as the source of pressure is removed. So in case of orthodontic treatment, if you change the force, this resorption will stop. In case of this here, it caused a resorption, but fortunately this patient, it's 40 years old. So the resorption occurred due to pressure of premolar for the mesial root, but for the distal root, it is no resorption and the premolar stopped here. So what I did, root canal treatment, and I will keep the tooth under observation. If I notice any sign of resorption here, we will go to surgical intervention of this premolar. And let's see this case after 1 year. We have no resorption here, and the resorption, the bone, no lesion here, and we gain the bone here. Another very important cause of resorption, which is chronic periapical periodontitis, which means if we have necrotic pulp and the tooth was not treated, it will cause apical periodontitis, and this periodontitis, it might cause resorption of the root like this case or like this case here. What about the treatment of external inflammatory resorption? A treatment is based on effective removal of the infected necrotic pulp tissues in the root canal. So the first thing you have to remember, I have to start root canal treatment to eliminate the source of infection. So a treatment arrests the resorption process, and it will create an environment conductive to hard tissue repair. So when we make root canal treatment, although here we have a huge resorption of this root, but the tooth is stable, there is no mobility, we have a huge amount of resorption of the root here. So what I'm going to do, I will make root canal treatment. I will remove all the necrotic tissues from here, and then I will make my obturation. So the mesial part, I will obturate it with gutta-percha and sealer, but the distal part, because of the resorption, I will place MTA. And now you can see this case after just 5 months. You can see here the resorption stopped, the bone is regenerated here, and we will keep the tooth under observation. It is essential to initiate root canal treatment as soon as radiographic signs of resorption are identified. So in any case, if you see any external inflammatory resorption, you have to start immediately the root canal treatment. So we have an exception here. The exception in case of replanted teeth. So if you have a valse tooth and you make replantation, you should start root canal treatment even without seeing any resorption. So the treatment should be carried out 7 to 10 days after replantation, even if there is no radiographic sign of resorption. So we will not wait resorption to occur. We have to start immediately making the root canal treatment. Look at this case here. This patient, he went to a dentist. This tooth was avulsed, and the dentist, he replanted it again and splinted it. And the dentist told the patient to come back again to make root canal treatment. But unfortunately, this patient, he did not come back again to his dentist. And he went to make a checkup after 6 months. And you can see here the external resorption started because this tooth was not endodontically treated. Resorption may give a tooth a moth-eaten radiographic appearance with irregular borders. So you can see here, this is a valse tooth replanted, no root canal treatment was done. After a few months, the patient came back because he had a sinus. X-ray showed we have eaten root. Calcium hydroxide is recommended to place in case of a valse tooth. Trop, in 1995, he suggested to place long-term dressing of calcium hydroxide. But the problem of long-term calcium hydroxide, it might make the tooth more brittle and increase the possibility of fracture. So I suggest to place it for 2 weeks only. Why calcium hydroxide is important? It can create an alkaline pH in the surrounding dentinal tubules, and it can kill bacteria and neutralize endotoxins, which is a potent inflammatory stimulus. So when we place calcium hydroxide, alkaline pH, and it will create alkaline pH, and it will neutralize endotoxins. So let's see this case here. We have 2 avulsed central incisors. I placed Dentin calcium hydroxide inside them. Then, after 10 days, I made my root canal treatment here. What about the prognosis of external inflammatory resorption? We can evaluate the healing by stop of the resorption process, resolution of radiolucency in the adjacent bone, and re-establishment of periodontal ligament. So when the resorption stops and the radiolucency of bone disappeared, and we have re-establishment of periodontal ligaments, we know our treatment was successful. So let's see here. We have a resorption here, external resorption. I placed non-sitting calcium hydroxide for about 15 days. Then I made my obturation here. So let's make the follow-up. Let's see this case after 2 years. You can see here the resorption stopped. No more resorption, no more radiolucency. We can consider it as a successful treatment. When the traumatic injury is severe and it will damage more than 20% of the root surface, so the pre-cementum, most of it was damaged, what will happen? Abnormal attachment can occur after healing it take place. So the bone, it will come in contact with the roots without an intermediate attachment apparatus, because the periodontal ligaments were removed. So the contact between bone and the root surface immediately will occur. So what will happen? This phenomena is termed as ankylosis. So now the root is bind directly with the bone. So we can see here we have no root, resorb occurred, and the bone trabeculae, it replaced the root here. So root is resorbed by osteoclast, bone is laid down instead of dentin, so they are slowly replacing the root with bone. How we know we have ankylosis? The ankylosis and replacement resorption are recognized by, first, when we check the tooth, we will notice it's the immobility of the tooth. So the tooth is like a rock. There is no periodontal ligament, so the tooth is immobile. When we make percussion test, we will hear atypical metallic percussion sound, which means there is no periodontal ligament there, and the tooth is binded with the bone directly. And because there is no periodontal ligament, the tooth will not grow, and we can see here the tooth may be in infraocclusion. What about radiographic feature? We could not notice the periodontal ligament or lamina dura, so the absence of periodontal ligament space is noticed in radiographic X-ray. There are a lot of things to talk about in case of resorption, but because of the limitation of the time, this is what I can mention this today, and I have a lot of questions here. I will do my best to answer. Is there any way to fill the internal resorption if we do not have if we don't have the gun? I could not, because we need soft getaberka to fill the resorption, the resorptive part. So I could not think with other than this. I'm so sorry for this. What if MTA pushed from the apex? Remember, MTA, it's biocompatible. So we are not afraid of pushing outside, but because I need to have a barrier to first, I use the getaberka at the apical part because I want to guarantee my apical part is completely filled and sealed. And the other thing, using MTA, it's not easy. So it's easier for you to just fill the apical part with the getaberka and the resorptive part with the MTA. Why don't we use gataperca in the coronal portion? You can use, it's like sandwich. You can use the apical part gataperca, resorptive part with the MTA, and the coronal part you can place again with the gataperca gun. Which irrigation solution we can use? It's a very nice question. Frankly, for me, I use sodium hypochlorite, but slowly and gently. And the accidents of sodium hypochlorite usually occurred if we push with force, and the expulsion of sodium hypochlorite went from the resorptive part. So if you irrigate slowly and gently, nothing will happen. All of those cases, I use sodium hypochlorite in irrigation. If we have not time for CBCT to differentiate between internal and external resorption, how we manage the case? Frankly, it is difficult to distinguish. Why I have to make distinguish? Because we have two techniques for obturating the defect. If it is internally, I don't need MTA. If it is externally, I should use MTA. So how I can know, depending on the two-dimension X-rays. And if you go to the recommendation of American Association of Endodontics and European Society of Endodontics, they recommend to use CBCT in case of resorption, because it is very necessary to make our differentiation. Is internal resorption is followed by radicular cyst or vice versa? No, no, it's not necessary. It's no, no. The question is about the severity of the resorption, and if the tooth is restorable, and if we can place the MTA and we still have good tooth structure, I will give the tooth a chance. But if it is destroyed, unfortunately, we have to go for implants. Orthodontic appliance effect, yes, as you can see here, unfortunately, inflammatory root resorption, it is the main cause. It's one of the main causes is the pressure. So if we have severe pressure or extreme pressure, we might have a resorption at the apical part. So because of this, when you make orthodontic treatment, we have to examine the treatment frequently, and we have to check there is no excessive pressure on this tooth. I will do my best to answer the question during today or tomorrow. I appreciate Woodbaker efforts for making us stay safe at home, and I wish for all of you to be safe in this era of Corona. Thank you again for watching, and be safe. Thank you.